Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. Today we talk to Dr. Christopher Bowlus, Division Chief of Gastroenterology and Hepatology and Professor of Medicine at UC Davis. So, first of all, welcome, Dr. Bowlus. It's great to speak to you once again. You're a great friend of PSC Partners and host of the conference. What we wanted to discuss today with you is just sort of there's been a lot of drug development and a lot of clinical developments in the investigation or in the treatment of PSC. And I wondered if we could maybe recap on these things briefly, if we could.
Yeah, there's been quite a bit of progress, both in terms of moving drugs along and I think understanding how we're going to determine whether drugs are effective or not. And that's still an area where there's a lot of unanswered questions, but there's becoming more clarity. So maybe just to give a little bit of overview first about how drugs actually get developed. Obviously, first you need to have an idea of how you want to target the disease. And in PSC, there are essentially, I would say, 3 different methods of targeting the disease. That is going after inflammation, going after the cholestasis or bile acids, and the third is going after the fibrosis. But even after you've decided that you have a good mechanism to go after, the question is, how do you know that a drug works or doesn't work in a disease that takes typically a couple of decades to progress to some clinical outcome? That means liver transplantation or needing some surgery or something else. And of course, we can't do a clinical trial that lasts that long. So we need what we call surrogate markers of clinical outcomes. That is a blood test or some other test we can do that accurately predicts whether someone's at greater risk of having one of these clinical outcomes years later.
To drill down a little bit on what you're saying sort of there's the 3 different things you can measure are basically whether or not the bile duct gets a stricture or is damaged, how much bile acid backs up in the liver itself, and also how much fibrosis or cirrhosis does that bile acid cause.
Right. So we can measure a lot of these things like inflammation, bile acids, fibrosis. And for some of these, it may not matter what we do to the markers if, in terms of what happens to an individual down the road. For example, the example of alkaline phosphatase in PSC is pretty typical. We think that if you have a low alkaline phosphatase, you will do better. However, we know from a study of URSO that, in fact, when you lower the alkaline phosphatase, that doesn't necessarily mean that you're going to do better. We can, URSO can lower the alkaline phosphatase, but it's not been shown to actually make people get better. And in fact, at very high doses, people do worse, even though the alkaline phosphatase tends to get better. So, what we need.
And does it help with inflammation at all, or do we know?
We don't really know about inflammation with URSO. But again, that's another question, is we don't even know that if we improve inflammation, that we're going to prevent progression of the disease. And one example for fatty liver disease, which is similar in that it takes years to develop, and we're still trying to figure out how we are going to measure improvements with therapies. Inflammation really doesn't predict whether someone's going to go on to need a liver transplant or not. It's really the fibrosis. And I think that's the key here, is that, at least in my way of thinking, fibrosis is sort of the common pathway of all liver diseases that then results in the complications of cirrhosis and the need for liver transplantation.
And in PSC patients, of course, from what I heard, I've talked to transplant doctors at times, and they say, of course, when they pull out the liver of a PSC patient, it's usually in much worse shape than they had anticipated.
Yeah, and the fibrosis in PSC is a little bit different, and that's, I think, where it makes it a little bit more difficult for us is that the fibrosis occurs mainly around the bile duct. So the rest of the liver can be relatively well preserved, but the bile ducts themselves are really where the fibrosis is and causes the problem.
And with the fibrosis, when we were talking about markers, we were talking about as well. I mean, I think from a patient's point of view, what most patients might be worried about is the CA19 or markers, cancer marker, because in a way, if their liver gives up, they probably, one probably has a reasonable chance of getting a liver transplant, provided you're set up in that way. But if you get cancer, of course, it's very hard to do anything.
Right. And I think, fortunately, the cholangiocarcinomas, the liver cancers, are relatively infrequent in PSC. There's still a concern there, but many more patients go on to develop cirrhosis than bile duct cancers. And clearly, we don't want a therapy that's going to increase that risk of bile duct cancers. But they're so rare, it's going to be hard to really identify a change in that. Though I think you bring up a good point also in that what patients also care about is how they feel. And so therapies we're looking at, really we're trying to prevent the progression to liver transplantation or complications of cirrhosis. But at the same time, we want therapies that at least don't make patients feel worse. We want them to, feel better, if anything. And so that's another area that is being developed, is how do we actually measure patient symptoms related to PSC, because it gets very complicated in PSC, where we're dealing also not just with the liver disease symptoms, but also the symptoms of inflammatory bowel disease often. And, if you're having abdominal pain, is it pain from your liver? Is it pain from your GI tract? These sorts of things are quite difficult to tease out and then be able to measure in a quantitative way, which is what really is required.
And sorry, I know we need to get to the important stuff, but in terms of, does pain mean anything?
So pain can mean things both in a sense of a clinical sense in terms of something going on in the liver, for example, cholangitis or obstruction of a bile duct. But it's also important in terms of, how people feel and how they function. So it's important in sort of both circumstances. So even if there's no kind of clinically significant change in how the liver is functioning or doing its daily things, the pain itself impacts patients. And so it's definitely an important part of the disease.
But it's not necessarily a marker of cholangiocarcinoma or... No,
absolutely not. No. Cholangiocarcinoma tends to sort of present insidiously with sort of worsening of liver tests, maybe some obstruction of the bile ducts leading to cholangitis. And that's where we really want to be thorough in our investigation and be sure this is not a cholangiocarcinoma, but just a progression of a stricture that's benign.
So back to the things that you were talking about now, the sort of three areas in which we're...
Yeah, so I think there are those three areas of targeting: the inflammation, the bile acids, and the fibrosis. And there have been studies looking at all three of those, and the ones that seem to be advancing most rapidly are those that affect the bile ducts. So if we look at the inflammation, there's been lots of studies in the past on these sorts of targets, and there are a few more that are being discussed and may come along, but so far, interestingly, they've really not been very effective. The bile acid drugs that are in development include one called Norurso, and that's the one that's probably furthest along in development. It is similar to Urso. It's a chemical that's just a slight alteration of Urso and has some theoretical advantages over Urso in its ability to protect the bile ducts. And it was studied in Europe, and in what we call a phase 2 study, showed a significant reduction in alkaline phosphatase in patients with PSC who went into the study with an elevated alkaline phosphatase. And so that drug is moving on into a phase 3 study only in Europe. It's being developed by a small company in Europe, so it's been limited to that region. In the United States, or internationally, I say more globally, the drug that's similar to obeticholic acid, which some people may be familiar with, which works by a couple different mechanisms, but mainly reduces the production of bile acids by the liver. That drug also showed promising results in a phase 2 study reducing alkaline phosphatase and is moving on to a phase 3 study. This is a drug produced by... this is Celefexar. It's produced by Gilead, and that's entering a phase 3 study now.
So what that does essentially is you take that, it reduces the amount of bile that needs to go through your strictured bile duct, therefore doesn't back up in your liver, causes less, because there's less bile, there's less cirrhosis of the liver. Is that how that works?
Yeah, right.
I mean,
so
it's an oversimplification, of course.
So bile acids, as you might imagine, given the name, they're acids, are fairly toxic substances. And when they're produced by the liver, they get out of the liver by the bile ducts, and they're in very high concentrations. But there are several mechanisms that protect the bile ducts from being injured by these bile acids. But when the bile ducts are injured, those protective mechanisms can be lost. And so you have the combination of bile acids not being able to move out of the bile ducts, so just sitting there, and the bile ducts are being exposed to this high concentration of bile acids. And then some of the protective mechanisms are broken down. And so we think that the bile acids cause sort of this secondary injury after the stricture is already formed.
I see.
And so with Urso or Norurso, what we think is we're basically diluting out some of the more toxic bile acids with less toxic bile acid, Urso. And then with these other drugs that affect the production of bile acids, we just are also reducing the total exposure to the bile acids, reducing the amount of bile acids, as well as potentially increasing the export of the bile acids out of the liver.
Well, like if you, is the bile acid produced by a certain mechanism, like when you eat a big steak, or like what's the, so if you only lived on snowflake crackers, for example, not that I would recommend it, but you probably wouldn't need a lot of bile acid to digest those.
So the bile acids that are produced can be affected by diet. And in fact, you see across species, different species of animals produce different types of bile acids based on what they eat, and that can occur across species as well as within an individual based on their diet. But at this time, we don't have a very large amount of information on the effects, particularly in PSC, of diet on bile acid production and which way we'd want to try to manipulate it. That's actually a project we're working on now in a couple of different fronts. So we are here at UC Davis looking at patients' diets. They're taking a diet history for 3 days, as well as taking what's called a food frequency questionnaire, which tells us how frequently they eat certain foods. And then we're measuring the bile acids in their blood as well as in their stool to see if we can identify which bile acids correlate with which dietary components. And then also looking to see what are the effects of the disease, stage on those bile acids. So that may give us a little bit of information to understand what the impact of diet is.
But it's hugely complicated.
Very, yeah. And then because we're also getting into what are the effects of bile acids on the microbiome. So there's this complex interaction there as well. So we've got diet, we have bile acids, we have microbiome, all kind of having interactions which can impact the liver. And so trying to tease out what are the important drivers of the disease, or if we can identify one of those, and can we manipulate it with diet or other interventions, is kind of the ultimate goal.
And is there evidence to because I know that the microbiome is very much in vogue at the moment, if you like, and for medical study, but it seems that there's some sort of conversation going on between the microbiome and the liver in PSC that's maybe gone wrong somehow. Would that be a bizarre interpretation?
No, it's absolutely correct. There's in fact a very interesting study that just came out of Japan, which is very intriguing and will be interesting to see over the next few years if it becomes an area of potential sort of therapeutic intervention. And so we've known for a few years now, not surprisingly, that people with PSC have an altered microbiome, so-called dysbiosis. And we see this in people with inflammatory bowel disease and all sorts of illnesses. But so far, until recently, it's sort of just been this, altered total microbiome. It's not anything specific. What the Japanese study did was they actually took stool from patients with PSC and ulcerative colitis, and then patients with just ulcerative colitis. And they put them in mice that were germ-free, so they did not have their own microbiome. And they could induce a PSC-like disease with the stool from patients with PSC, but not with just the ulcerative colitis. And then they went further and looked for if they could identify specific bacteria in the stool of these PSC patients. And in many of them, there were a combination of 3 bacteria, which are, for the most part, relatively common, but they have very maybe specific subtypes of these bacteria, which have specific properties, one of which is called Klebsiella pneumonia. And the strain they identified actually creates pores in the intestinal lining cells, the epithelial cells, which they suggest leads to the so-called leaky gut of PSC. And so, and they went beyond just their little group of PSC patients. I think they had like 19 patients in their initial study, but they actually looked for these bacteria in a larger cohort and identified them in a very high percentage of patients. And so if this holds up, we get beyond sort of just, thinking about an individual kind of global sort of dysbiosis, and we need to do something to rebalance it. We have actual targets to go after, and so that's kind of interesting. And the other part that's interesting, there's another paper that came out right around the same time, which was looking at lupus, another autoimmune disease, and they found one of these bacteria that the Japanese group had found. They found the same bacteria in a lupus model, and then also found it in primary biliary autoimmune hepatitis. So I think there's some really interesting findings that in the last year suggesting we've made some progress in understanding what specific microbes we could, focus on and potentially manipulate to alter disease.
Are there any theories as to how those particular bacteria are introduced into the body, or as you say, they're relatively common? Are they?
Yeah, they're relatively common. But even within a specific bacteria, they carry certain genes are genetically distinct from one another. So even though we say, for example, Klebsiella pneumonia, one Klebsiella pneumonia may act a bit differently than another one because they have some additional genes or differences in genes. And so that's where we've got to get beyond sort of just the classifications we have and go deeper into what are the actual genetics of these individual bacteria and how they arise originally, unclear, I would say, at this time.
I'm going to talk to another person specifically about vancomycin, but would this explain why people feel a decrease in their symptoms? Or I don't know if there's any clinical studies at all on vancomycin or whether or not it works, but it's all over the news groups at the moment.
Right. So the vancomycin study, what's been published has been very limited, but it might explain some of the impact of what's been reported. There is a clinical trial, randomized clinical trial being initiated now. The FDA is funding one that Keith Linder is running. So hopefully we'll have some very nice sort of data on vancomycin in PSC and see if there's some signal there to suggest that it's effective clinically. One of the issues the nice thing about the mouse study I was just talking about is we find these associations in patients, right? You find that a certain bacteria or whatever it is associated with the disease, but you don't know if it's cause and effect or if it's just the disease leads to this association. The mouse, right? So, but the mouse studies, they actually took the bacteria, put them in there, and generated the disease. So that leads a little bit more evidence that these bacteria actually are causing the disease. Because one of the things we could do is if you go and you eliminate these bacteria, you may have absolutely no impact on the disease because they're just sort of, a result of the disease as opposed to driving the disease. And so there's still a lot of work to be done to demonstrate that. And that's the case, whether it's vancomycin or other approaches to alter, these bacteria. Then the other drugs that are kind of in development. So we were talking about the Celefexar, and also within there, before I get to the NGM drug, the Intercept obeticholic acid also reported phase 2 data, and similar results to the Norurso and the Celefexar. All reduced alkaline phosphatase, probably in a similar magnitude, very similar results. And I don't think Intercept's made any decision or hasn't announced any decision on whether they're going to move forward in PSC or not. And the sort of
Heather Francis is also, I think she was speaking at the conference last year. She had done some study into using URSO and sort of antihistamines. Have you looked across that at all?
Yeah. I'm not aware of any clinical trials going on in that. It's very interesting hypothesis, and there's a lot of animal data they have on that. But I haven't seen any studies looking to translate that into humans yet.
Yeah, I think you're right.
Though it's an interesting approach. So the NGM282 also works in a similar manner, same pathway as Celefexar and obeticholic acid in a way. And interestingly, although it did appear to reduce bile acid synthesis, it did not change the alkaline phosphatase. But what it did do was improve markers of fibrosis. These are markers that are found in the blood, and they rapidly reduced in patients that got the NGM 282 drug. Now, these markers have been linked to clinical outcomes. It's not clear that they are necessarily going to mean anything, or what amount of reduction you have to say that they're, meaningful. So there's still a question there, I think, in terms of whether that drug will go forward or not. But it was a very interesting example, I think, of how we have some difficulty deciding on whether a drug's going to be effective or not, because this drug did not improve alkaline phosphatase, which is sort of the marker we've been using for effectiveness, but it did reduce other markers of fibrosis, which actually may be more important in terms of predicting effectiveness.
So that would mean that basically that the liver would be less cirrhotic, so there would be at least a longer time to transplant, if not being able to put it off completely. If a PSC patient now is alive in 10 years, and we should be able to get the disease under control.
Yeah, so I think in 10 years, I would hope that we will have a drug, at least one, that slows the progression of the disease in the majority of patients, or slows the disease in all patients, but for example, the majority of patients won't have to be too concerned that their disease would progress to the point of needing liver transplantation. They would just go on with their life and have to continue to take this medication, but it would essentially halt progression. There probably would be still a group that, for whatever reason, either the disease is diagnosed at a late stage or it's just more aggressive, still progresses. I don't think we can expect, a magical cure, but I would hope that we'd have a drug or several drugs that will slow the progression of the disease. And then I think we'll have a little bit better tools available for diagnosing cholangiocarcinoma, whether that's with blood tests that are used for screening and surveillance, to looking for it early, and then going on to more sophisticated imaging tools like the ones we talked about. That would be, I think, reasonable to expect in the next 10 years or so.
Well, thank you very much, Dr. Bowlus. It's great to talk to you.
Good to talk to you too, Neil. Thanks for the opportunity.
Yeah, and we look forward to this great work that you're doing on our behalf, and we really appreciate it.
Thank you. Take care.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.